is a clinical psychologist and associate professor in the Substance Abuse Research Division at the Wayne State University School of Medicine in Detroit, Michigan. He's also the director of the Problem Gambling Clinic at Wayne State and the president of the Michigan Association on Problem Gambling. So without further ado, Dr. Ledgerwood, you go ahead and take it. I'm going to go
Robbie.
back into oblivion here. So
thanks for the invite.
Sure.
I can actually correct my your intro. I'm no longer president of the Michigan Association. I'm the past president.
Past president.
Now I'm secretary on the board there. So,
oh, you're okay.
Yeah, my role has changed a little bit. So.
I'll mark through president and put secretary now.
Okay,
so, but
there you go.
But thank you for the update.
Okay, thanks, Robbie. All right. Hi, everybody. It's great to be back talking to you again. I see we're up to 50 people, which is terrific. Most of you hopefully are outside enjoying the sun, given that you're in Illinois. I suspect you're getting similar weather to what we have here in the sort of southeastern Michigan and southwestern Ontario region, where I am, where it's currently beautifully sunny and approaching 70 degrees. So hopefully you guys are getting similar weather over there. I'm going to talk to you a little bit today about therapy approaches for gambling disorder, and specifically going to focus on motivational interviewing. In gambling, sometimes also called motivational enhancement therapy and cognitive behavioral approaches. I will sort of give a caveat at the very beginning of this presentation, is that 1 hour is nowhere near enough time to really review these treatment approaches for gambling disorder. And I have way too much material, but I'm going to try and get through it as best I can with a little more focus on the theory and sort of the focus, the clinical focus behind these treatment approaches than on the research. So I'm going to do it. I'm going to start with a little bit of research on these approaches and then move into talking about each of them and giving a brief overview on each type of therapy, motivational interviewing and CBT, as they're applied to people with gambling disorder. And as I go through the presentation today, as normal, I usually sort of think about what are the important questions that I really sort of want people to think about as I'm talking about these treatment approaches, in addition to what I'm talking about, which are the different treatment approaches. I want you to think about sort of other things too. So for example, what are the most effective treatments for gambling disorder? We will cover that a little bit in the research section. I want you to think about what treatment approaches do you use? Do you tend to use motivational interviewing approaches or cognitive behavioral approaches? Or do you tend to use other sorts of approaches, and how would you describe those? Is there a difference in outcome between what we call evidence-based approaches like motivational interviewing and CBT versus more supportive or treatment as usual types of approaches that many of us often sort of rely on in our day-to-day practice? Do we use evidence-based treatments? And if not, does it matter? So in addition to what I'm going to talk about today, I want you to think about what I'm talking about within the context of these questions. If we have time at the end, there's some interesting findings that I can sort of show you, or I can save them for another talk. But just jumping into it, I want to talk very briefly about some of the research on motivational interviewing and cognitive behavior therapy for gambling disorder. And I'm going to start off with a study that we published in the Journal of Consulting and Clinical Psychology in 2008. I was lucky enough to work with Dr. Nancy Petrie, who was unfortunately passed away a couple of years ago, but she is really the person who is responsible for adapting cognitive behavioral treatment approaches and motivational enhancement treatment approaches to gambling disorder in the gambling disorder field. And she conducted a number of studies. I believe she just published about 4 clinical trials on gambling disorder and specific treatments. And I want to focus on one of them just very briefly. And this was a study where we actually did a brief intervention, brief CBT or MI, with people who had either problem gambling, so they had gambling symptoms, but it didn't quite rise to the level of gambling disorder, or they had gambling disorder and they weren't that interested in getting treatment, so we did brief intervention with them. We had 180 individuals, problem gamblers, recruited from the community. Most of them were recruited from community dental and medical clinics where people would go if they didn't have medical coverage, or they were recruited from substance abuse treatment clinics. We used something called an intent to treat analysis, which basically means that if we randomize a person to a treatment, we would follow them up all the way through to the final follow-up, regardless of whether or not they finished the treatment. So we would count them in that group. This is a very busy graph. Just very, very briefly, those 180 people were randomly assigned to one of 4 treatment groups. There was an assessment-only condition. 48 people ended up in that group. There was a very brief advice condition. So remember, these are people who didn't want treatment. So they got 10 minutes of brief advice to stop gambling. 55 people were randomized to a group that focused only on motivational enhancement therapy, which is a form of motivational interviewing. And 40 people were assigned to a 4th group where they got 1 session of motivational enhancement therapy and 3 sessions of cognitive behavior therapy. And we followed them up for 6 weeks and nine months, basically, after their entry into the study. This graph basically shows that people were in their 40s overall, and there were really no differences between groups in terms of age, gender. Most, except for brief advice, had slightly fewer men. Racial identification, yearly income, years of education were all fairly similar. On average, participants had about 5 to 5.5 problem gambling symptoms. According to the NODS, which is a DSM-4 based measure of what we used to call pathological gambling. Now we call gambling disorder. Their South Oaks gambling screen was a little bit higher. The number of days they gambled in the past month was anywhere from 16 to 19. They spent on median $300 to $500 in the past month on gambling. And in terms of gambling activities, they mostly engaged in scratch tickets, slot machines, or cards. And this was done back in the mid-2000s, so there were fewer casinos around at the time. In terms of our session attendance on this particular study, we had 100% of our participants complete the 10 minutes of brief advice. About 95% completed the single session of motivational enhancement therapy, and those sessions were 50 minutes long, so a typical psychotherapy session, individual session. And in the final group, the group that got motivational enhancement and cognitive behavior therapy, just over 87% completed the first session, motivational enhancement session. Just over half completed 2 sessions, just under half completed 3 sessions, and just under a third of participants completed all 4 treatment sessions. So you'll see here that for 2 of the groups, brief advice, motivational enhancement, they only got 1 session each, but the motivational enhancement plus CBT got up to 4 sessions. And the rates are kind of low as far as the number of people who completed all 4 sessions, but this is actually quite similar to most studies that are out there that look at brief interventions among people who are not interested in receiving treatment for their gambling problems. So what did we find? This graph is maybe a little bit tough to sort of interpret, but these are mean scores on a measure called the Addiction Severity Index Gambling Scale. So it's a severity score for a person's problem gambling. And you'll see here from the left-hand side to the right-hand side across time, most of the participants sort of had similar ASI gambling scores when they first came into the study. When we followed them up to the six-week point, we see that basically the motivational enhancement group was the worst, actually, followed by the control group, followed by the MAT plus CBT group. And in this case, the best group turned out to be the brief advice group. So the folks who got just 10 minutes of brief advice actually reduced their gambling severity more than these other 3 groups. When we go out to the 9-month point, we see that that group sort of rebounded, and they're actually right on top of the control and MET groups. And by the end, it's actually the MET plus CBT group that actually performed the best on the ASI gambling scores. We also looked at dollars wagered over time. And in this case, we see a sort of a slightly different, although fairly similar sort of set of scores. We see that at the very beginning, all four groups more or less clustered together at baseline. And as we go across, not surprisingly, the control group didn't really reduce their dollars wagered very much. Again, we see the brief advice group was the group that actually found had the greatest reduction in the amount of money that they were gambling. And I should just sort of mention that this was a log transformed value, so it's not actually dollars on the left-hand axis here. We also see that the motivational enhancement group and the MAT plus CBT group fall in between the control group and the brief advice group. Well, this is really interesting because this is not what we were expecting to find. We were expecting to find that the MAT group and the MAT plus CBT group would perform best compared to both the brief advice and the control condition. We were scratching our heads about these findings, and we had no idea sort of why we got the results we got. We conducted a second study where we used the exact same procedures, except instead of recruiting people from substance abuse clinics and medical and dental clinics, we recruited college students. And we got a completely different set of results. We still found that the control group didn't do very well. But rather than the brief advice group doing better than the other two groups, we actually found the MET plus CBT group did the best, followed by the MET group, followed by the brief advice group. So what this led us to actually believe is basically, to a certain extent, how well your treatments are going to work will depend on a lot of factors other than just the treatment itself. In this case, we believe it were characteristics of the treatment sample, and it's very difficult because there are different studies to determine how those groups would differ, other than things like socioeconomic status, age, or perhaps race and ethnicity, and so forth. But for the most part, what it showed us is that even though CBT and MI are often touted as the best treatments for gambling disorder, there may be other approaches that are also beneficial for people with gambling problems. In this case, these folks basically were not interested in getting treatment for their gambling problems, and they may have appreciated a very brief approach, brief advice to reduce their gambling. So that's something to consider as we talk about the different treatment approaches, because it's important to understand that even though CBT and MI are talked about as being efficacious and effective, it doesn't necessarily mean that they're going to be much more effective than other treatment approaches. And in terms of what's been studied out there, there have been numerous clinical trials now that have looked at gambling disorder treatment. And there was a really great paper that came out in December of 2017 in a special issue in the Journal the Journal Psychology of Addictive Behaviors. And it was actually written by Nancy Petrie and Carla Rash, who are from the University of Connecticut School of Medicine. And they basically looked at all of the randomized controlled trials that were out there to determine which treatment approaches work the best, essentially in terms of those that have been actually studied using controlled clinical trials. So this very complicated graph here basically shows that they started off finding, when they did their initial search of the literature, over 900 articles that were potentially eligible for inclusion in their study. And what it all boiled down to was there were basically about 22 articles based on 21 studies that met their criteria for inclusion, which were things like it had to be a clinical trial, had to be very rigorously done from a methodological standpoint, it had to include a control group or a waitlist group, or it had to compare two treatments. It had to be written in English, it had to be published in a peer-reviewed journal to be included in this review. So with 927 initial hits, we or 964 initial hits rather, we get down to essentially 22 papers based on 21 studies. So what this basically shows us is there's really not a lot of literature, solid literature out there testing the effectiveness of gambling treatment. And the types of treatment that they identified in literature that have been looked at in clinical trials were cognitive treatment approaches, cognitive behavioral approaches. I'll sort of describe the difference between those two in a bit. motivational interviewing and motivational enhancement approaches, self-directed approaches, and brief feedback approaches. So brief feedback would be brief advice, giving people advice about how they fit into the diagnostic structure, how many symptoms they had. Now you'll notice that one of the things that's completely missing on this list is Gamblers Anonymous or 12-step approaches. And that's because Gamblers Anonymous and other 12-step treatment approaches are really structured in such a way where it's virtually impossible to do a clinical trial because of the anonymous nature of the approach, and because it's very self-directed. You can go to any GA meeting you want. You can not go. You can go once. You can go 1,000 times. Ultimately, it's up to you where you go, what meetings you go to, and so forth. It makes it very difficult to study in a traditional clinical trial. So we don't see much there. Here's what they essentially found. They found that the evidence for the efficacy of treatments is inconsistent across their studies, which is sort of consistent with what we found in our brief intervention study. Although CBT, cognitive behavioral approaches, had the most evidence for efficacy among all of the behavioral treatment approaches. Motivational interviewing approaches alone did not seem to be efficacious when they weren't sort of added to other programs, but they did seem to help when added to cognitive behavioral approaches. So we often see that motivational interviewing or motivational enhancement approaches tend to be used first, followed by a more cognitive behavioral type of approach when we're treating problem gamblers. And brief interventions like the ones we did may be modestly effective for people when they want to reduce their gambling, but they're best used with people who are not generally interested in going to long-term treatment. So in addition to these findings, they also listed a number of things to consider. One is patient population. So some may benefit from brief intervention, but some may want longer face-to-face therapy. We saw that in our two studies, our two brief intervention studies, that the folks who are in the recruited from the medical clinics and the dental clinics and so forth seem to do better with a very brief intervention, a very brief advice intervention, whereas the college students seem to do best with the longer, more comprehensive intervention. Long-term effects, we don't necessarily know very much about the long-term effects of treatment. The clinical trials that have been done so far have not really gone beyond 12 months in terms of looking at effects. And we also don't have any research out there to demonstrate whether there's a significant difference between effects of people going through long-term therapy compared with natural recovery. And we do know that the vast majority of people who recover from a gambling problem actually recover naturally without any treatment whatsoever. As a matter of fact, the numbers are as high as 90% of problem gamblers who recover from gambling disorders. The outcomes were all over the place. The types of outcomes that they studied, where they looked at dollars gambled, days gambled, gambling disorder symptoms, gambling disorder severity, other types of measures like depression or quality of life, that sort of thing. And there's also a question of what's more important to look at. Is it important to look at absolute abstinence from gambling, or is controlled gambling an appropriate goal or an appropriate outcome that we should also be looking at in these clinical trials? And in comparison between different interventions has been much more difficult to establish. There are very few studies that compare two different sort of evidence-based interventions. And no clinical trials have actually looked at the effectiveness of gambling disorder treatment for specifically addressing co-occurring disorders that contribute to gambling disorder. We know that it's the rule rather than the exception that people with gambling problems have additional co-occurring problems. So those of you who saw the co-occurring disorders presentation previously, you know that as many as half of people with gambling disorder have a major depressive disorder. More than half tend to have a history of substance use disorder.
Hey,
I
Dave.
see Robert popping in here. So is there a question?
Sorry. Yeah. Quick question Marie had. She wanted to ask if solution-focused therapy was considered in any of this?
No, there's no controlled clinical trials on solution focus specifically.
Okay.
There are a number of trials that look at various other sort of forms of cognitive cognitive behavioral types of approaches,
Mm.
but not solution focused. No,
Okay.
not in any clinical trial that's been considered in here.
Gotcha. Okay. Thank you. Thank you, Marie.
Okay. So that's all I'm going to say about the research literature to be for this particular presentation, except to say when thinking about the types of treatment approaches you're considering, just remember that we know far less than we don't know. There's so much about the research literature that's very much just based on clinical trials that have been done in university labs without any sort of consideration of which treatment approach is best for people with co-occurring depression or substance use problems, uh, which treatment goals are most important, control gambling or abstinence only, and so forth. And the only reason for that is because we would need a lot more money and a lot more time to do that research. And that's something that hopefully down the road, we will have more opportunity to conduct clinical trials to say, focus on people with gambling disorder and depression, or gambling disorder and high impulsivity, or other things. But today, we just don't have those kind of resources. So we're kind of stuck with what we have in terms of the research literature. So now that, Robbie, now that I've sort of shut you down here, we're ready for poll question number one.
I guess I need to get my sound on.
Okay, or do you want to read it? Go ahead.
No, I can't. Okay, what treatment approach has the most evidence for efficacy? Is it A, motivational interviewing? Is it B, brief interventions? Is it C, cognitive behavioral therapy? Or is it D, Gamblers Anonymous? What treatment approach has the most evidence for efficacy? Is it A, motivational interviewing? Is it B, brief interventions? Is it C, cognitive behavioral therapy? Or is it D, Gamblers Anonymous?
All right.
Yep. So we're already up to over 80%. So folks are answering quickly.
All right.
And T minus 10 seconds. It looks like we're over 90%. So
Okay.
there we have it.
Okay. So we got those of you who said cognitive behavior therapy, you're correct. So
Yeah.
now evidence for efficacy, meaning that there have been clinical trials that have demonstrated the effectiveness or efficacy of that approach. So as 29% of you said brief interventions, which I may have tricked you up a little bit there because I was talking about that initial study where we found brief intervention or brief advice to be more effective than CBT and MI for that particular study. But Dr. Petrie's review actually demonstrated that CBT actually has the most evidence for efficacy so far.
Wow.
For those of you who said GA or MI, unfortunately, in the gambling world, not so much yet. MI has efficacy when it's added to CBT.
Great.
And there's been no clinical trials on Gamblers Anonymous.
That's right. Okay.
Okay, great. Thanks, everybody. Let me get rid of this. So let me jump now and talk a little bit about motivational interviewing. And this would be an overview for most of us. I would imagine most of you have had training on motivational interviewing at some point in time in the past. So this is more of a reminder or review of the basic principles of motivational interviewing. And with everything I said and the limitations of the research literature, I still really stand by a motivational interviewing approach as an overall approach for working with clients. I do find that it really helps to disarm a client in terms of when a person is sort of more resistant or more challenging to work with. And it also helps the person to understand that they have ambivalence, no matter how much they have a buy-in in terms of recovery, there's always going to be something they're ambivalent about. And for people to acknowledge that ambivalence and to own it and to sort of help them work through it, I think motivational interviewing is a very, very useful approach. I'm not going to spend too much time on every single slide here. You might find that I kind of skip through quickly, and this is one of those. It was developed by Miller and Rolnick, Bill Miller and Stephen Rolnick, rather. And it's a treatment approach that has actually been studied in the substance abuse literature in literally hundreds of clinical trials, and it's been applied not just to substance use, but a number of other health problems. It is a directive intervention. A lot of people consider it to be somewhat non-directive, but it is directive in that it's helping the person sort of go towards a specific kind of outcome, a recovery outcome. It's client-centered. It's a method for enhancing intrinsic motivation to change one's behaviors by exploring and resolving ambivalence. And we talked about ambivalence briefly. I don't consider it to be really a style or a set of tools like maybe cognitive behavioral therapy approaches or therapy like CBT. I consider it more of a style of working with people. As I said, it's client-centered. It involves actually listening to clients. It involves reflecting back their emotional experience, their cognitive experience, their motivational experience, and even just what they're saying to you. But it's focused on the client's ambivalence, and it is goal-directed. We're going to talk a little bit about that. When we see people with gambling problems, we can think of them sometimes in terms of the stages of change. And I'm going to assume that all of you know the stages of change from pre-contemplation, where a person doesn't believe they have a problem, has no intention of changing their behavior, all the way up to maintenance, when they've enacted numerous recovery changes in their lives, gotten to the point of overcoming addictive behaviors, and they're trying to grow and self-actualize and sort of improve their lives. And we would love to believe that recovery occurs in a straight line, like on this graph, where you start at pre-contemplation and go all the way up through contemplation, preparation, action, and maintenance, and come to a point of being self-actualized and being ready for the world. But ultimately, that's not what happens. What typically happens is we have lots of stops and starts, and a person may end up in recovery for years and years and then have a relapse. As a matter of fact, there's a fairly famous story about Peter Jennings, who was the ABC news anchor for many, many years, who quit smoking back in the 1970s, and he was able to abstain from smoking cigarettes for decades until 9/11 happened. And then every single night, he was reporting on the 9/11 disaster and the people involved and what happened and the outcomes and everything else. And of course, he resumed smoking cigarettes because that amount of stress was too much for him to handle. So after probably 25 to 30 years of recovery from nicotine addiction, he went back to smoking. And unfortunately, he went on to pass away from lung cancer related to smoking as well. But what this basically means is that gambling, like every other addiction, is a chronically relapsing condition. We go back and forth. When we're talking about motivational interviewing, the overall goal of this approach, according to Miller and Rolnick, is to increase intrinsic motivation so that change arises from within rather than being imposed from without, and so that change serves a person's own goals and values. Now, if I want to break this definition down, I think it's important to think of it in terms of how we approach our clients. So increasing intrinsic motivation is important, but what is also essential here is that it arises from within rather than being imposed from without. So for example, if someone gets in trouble with their gambling and they end up getting on probation or something like that, that's an external contingency. And yes, that can help and change a person's behavior, but that's not necessarily going to inform their own intrinsic motivation. So what we want to do as therapists is get people to examine their ambivalence about their gambling, their recovery, and so forth, and identify that intrinsic motivation the person already has, and have the client explore that and bring that out a little bit more. The best way to do that sort of involves the last part of this definition, using one's own goals and values. So if you can get at what is important to a person and how their addictive behavior interacts with what's important to them. And usually the case is that the addictive behavior interferes with a person's ability to engage in those activities or those values and those goals. Then you can use that to help the person become more clear about what they want to do and what they need to do in terms of their addictive behaviors. Now, for those of you who know MI, you know these are fairly basic principles based on sort of the spirit of MI, based on Rolnick and Miller and Rolnick's original book. In motivational interviewing, we're interested in a collaborative relationship. We're interested in evocation and respectfulness in the therapeutic relationship. We'll talk very briefly about each of these concepts. When we talk about collaboration, we're talking about the therapist approaching the client as a partner, not as an authoritarian sort of authority figure. The idea is to help the client to explore their experience and to support them through this exploration. A great, I think, example of this is if you ever get a chance to go on YouTube and look up videos of Carl Rogers, the famous humanistic experiential therapist doing therapy with someone. If you watch him for over an hour, he'll never tell a client what to do or what he or she should be thinking. What you'll see is that Dr. Rogers is taking through the client through a process of exploration and helping the client sort of explore his or her own experience, feelings, and motivations through his genuine interest in the client. So the therapist's job is essentially to form a bond with the client, to show interest in what the client is experiencing, and help the client to explore his or her own experience rather than trying to interpret everything. We do this through something called evocation. And evocation is basically eliciting or drawing out motivation from a client. I do a lot of work with psychiatry residents and with PhD clinical psychology students who are learning how to do psychotherapy. And evocation is one of the most important things that they learn to do. It's also one of the most difficult things that they have to try and learn to do. Evocation basically means getting the client to say how he needs to change, rather than you telling the client how he needs to change, or she. So for example, I could think of times when my students were working with someone who was trying to abstain from heroin and cocaine while they're on methadone in treatment. And you know, my students would be inclined to sort of say, so it seems to me that using cocaine is actually really bad for your heart and you're putting yourself at risk of further heart problems. It would be much more powerful if my therapist students would find some way to get the client, him or herself, to actually say that, rather than the client saying that to the therapist saying that to the client. That's really tricky. It's hard to get people to sort of evoke those sorts of responses unless they're ready to evoke those things. But it is part of this. Ultimately, when it comes down to it, your relationship with your client has to involve a respectful sense of autonomy. So all responsibility for change lies with the client, not with the therapist. And this has been something that a lot of my students have a really hard time with. It's not up to the therapist to fix the client. It's up to the client to explore and find a better way for themselves. So, and that's what we mean by respect, essentially, respect for autonomy for the client. They're free to accept your counsel or not accept your counsel. And this can be really challenging for a therapist in terms of countertransference, when we feel like, wow, if you just did X, Y, and Z, your life would be so much better. And it's frustrating because you won't do that. And I have to see you every time and nothing ever changes for you. Ultimately, it's not about the therapist's experience, it's about the client's experience, and he or she has to be responsible for that change. There are guiding principles regarding motivational interviewing: expressing empathy, developing discrepancy, rolling with resistance, and supporting self-efficacy. I'm going to talk about these very quickly. Empathy is of huge importance. So acceptance of the client, acceptance of where he or she is at, helps to facilitate change. If you can accept that somebody comes into your office and they don't feel like They're totally ready to change their gambling behavior. Sometimes they feel like they have a problem. Sometimes they feel like it's everyone else who has a problem. If your response to them is to sit down and say, no, 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 you have a problem, you need to change your gambling behavior, that's not empathetic, and that's also not going to facilitate change, because it's going to cause the client to essentially dig in. What is more useful is for you to reflect back that. So for you, it feels like sometimes you have a problem, but sometimes it feels like other people are being really hard on you. That's a fair statement, because it actually accurately reflects what the person is feeling and thinking. That is empathy. You're sort of putting yourself in that person's shoes. We approach this as though ambivalence is a normal state, because ambivalence is a normal state for all of us in most things in our lives. If you think about it, for just about anything. So for example, we're in a pandemic. Many of us are stuck at our houses and we can't really go anywhere. We know we're going to be on a Zoom call today, but we're ambivalent about whether or not we're going to share our screen, right? Because that would mean we have to get dressed up and better clothes, maybe get out of our pajamas and so forth. In some cases, our sort of our approach will be essentially to sort of make a decision one way or another. Either I'm going to stay in my pajamas, I'm going to keep my screen blocked, or I'm going to get dressed up in case my screen, put my screen on. So we're ambivalent about even the simplest things in our lives like that. Now imagine somebody with an addiction, how ambivalent they're going to be about changing many of the things in their life. And it's not just about their gambling. So for example, I worked with a student who was working with a patient in methadone treatment some years ago, and he was fully 100% on board with changing his substance use. And he did. He stopped using heroin, cocaine, and alcohol and benzodiazepines, and he even quit smoking. He came into a smoking trial that I was doing, and he was doing great, except for one thing. He had a lot of pent up emotional stuff, relationship stuff, and he did not want to go there in therapy. He would not address his emotional experience. His ambivalence was essentially he would not address emotions in therapy. And when those emotions caught up to him and he got too overwhelmed, what happened? He relapsed. He started smoking again. He started drinking again. He started taking cocaine and benzos again, eventually heroin as well. And we were lucky enough to keep him from dropping out of the clinic and keep him engaged until my student who was working with him finally said, "You know why you relapsed? Because you wouldn't address all this emotional stuff that you're experiencing." That's not a very MI type of response, but it seemed to work, and he started to talk about it. And as he started to talk about it, he was better able to cope with it, and he stopped using heroin, stopped using cocaine, stopped using benzos, and he quit smoking again. And I came to actually work with this gentleman about a decade later, and he had been clean for that past decade, and he went into recovery, full recovery. He got training in substance use, and now he's a peer counselor. So it's important to address these aspects. And this slide that I'm putting up now, essentially about empathy, sort of reflects what I just said. You want to be non-judgmental. You want to be supportive and knowledgeable. You want to be able to sort of reinforce the client whenever possible. It's about listening, which is really difficult to do. You can gently persuade people, but understand that any decision to change is with the client. And it's important for you as a therapist to provide support. The next thing that I really want to sort of focus on is sort of developing discrepancy. And this is another sort of aspect of motivational interviewing that is super important in terms of dealing with ambivalence. The idea here is that all arguments for changing one's behavior should come from the client, not the therapist. That doesn't mean that the therapist doesn't say anything. But what it means is when the therapist repeats back what the client is saying, everything should be in line with what the client has said. So change comes from a discrepancy between one's present behavior and one's important goals or values. So you remember from that definition of MI, I said that basically what's important is people will change their behavior, based on their intrinsic motivation, and their intrinsic motivation is based on one's important goals and life values. Well, your job as a therapist is to remind the client of what they said their life values are, not what you think they might be, but what the client has said they are. So when we're talking about motivational interviewing and developing these discrepancies, we're talking about the discrepancy between two different types of talk: change talk and sustained talk. So change talk is basically talk in the direction of recovery, talk in the direction of changing addictive behaviors, and sustained talk is talk that maintains the status quo, uh, maintains the person in that sort of addiction related sort of framework, right? And developing discrepancy is a way to help increase the tension and move the conversation forward. It helps to change a client, challenge the client to examine inconsistencies between his behaviors and his goals and values. Um, and it really comes down to the way it's put out there is usually done in a very non-judgmental way. And the idea is to get the client to understand that you want to understand how they come to their conclusion based on their behaviors, based on their goals and values. So with problem gamblers, you might say, so on the one hand, you and your wife are fighting a lot, and you have told me that this has upset you very, very much. You're wanting, for example, to have a solid marriage. It's important for you to be a good husband, and you grew up in a household where your parents fought a lot, and for you, it's a value that you try and work on creating a good marriage with your spouse. But on the other hand, I also see you saying that this gambling is causing a great deal of friction, a great deal of problems, that the two of you are even talking about potentially divorce. So I'm wondering, given these two sides of this equation, how do you make sense of this? And what I often do is I will almost, like, with my hands, hand it back to the client and sort of present it in a non-judgmental way, and you say, I want to know what you think of this. And then you kind of sit back as a therapist and you be quiet for a while, because it's really about the client working through that discrepancy, that type of ambivalence, of developing the discrepancy. You as a therapist have sort of created this sort of tension through highlighting an important inconsistency in the client's experience. And the client can work that through at this point. So it's very, for me, developing the discrepancy is almost the most important thing that we can do, aside from just listening to our client in a motivational interviewing approach. Rolling with resistance is important. It's important not to argue. It's important um, uh, not to hit resistance head on, but rather to pivot. So for example, if you say something like, wow, your marriage is really on the rocks because of your gambling, and then your client says, no, I think she just doesn't understand me. Your job isn't to say, yeah, but you told me all this stuff about your gambling, and that she's asking for a divorce, and that you're worried and you really want to be a good husband. That would be sort of hitting the resistance head on. Uh, a way of sort of rolling with that resistance might be to say, so I'm guessing I don't have it quite right. Can you sort of let me know, what do you think is going on there between you? So you're sort of rolling or pivoting away from the resistance. And supporting self-efficacy. So believing in the client is important, believing that he or she can change his or her behaviors, and conveying that confidence to your client is very important. Because if a counselor or a therapist doesn't believe in the client's ability to change, then that's going to become a self-fulfilling prophecy, and the client isn't going to change. But if the clinician conveys a sense of confidence to the client, that can also become a self-fulfilling prophecy, and can help the client change as well. There are sort of basic methods that I think we're not going to get into today, because they're sort of more fine-grained, but just basically using open-ended rather than closed questions can get more information and get people to talk more. Using affirmations, so telling people, hey, it's really great you've come to treatment. this is obviously important to you, those sorts of things. Reflective listening, which can involve simply saying back what the client has said. It can involve reflecting back what you heard in terms of their affect or their cognition or their motivation. It can also be involved in sort of double-sided reflections and sort of reflecting back two sides of the argument that the client has given you. Summary statements and eliciting change talk are all very important. So I'm going to flip through a few slides now and just sort of get to our poll question, our second poll question. Robbie?
Yes. Let's get to the second one. Let me launch it here. And it asks, which of the following statements is, boy, I must have written this wrong, Dave. I apologize. Untrue about motivational interviewing.
Untrue. Yeah, which of the following statements is untrue?
Untrue. Sorry, guys. Is it A, motivational interviewing is a form of treatment that is non-directive? Is it B, interventions are more powerful when the solution comes from the client than from the therapist? Is it C, all responsibility for changing one's behavior lies with the client? Or is it D, developing discrepancies help to elicit change talk? Which of the following statements is untrue about motivational interviewing? Is it A, it's a form of treatment that is non-directive? Is it B, interventions are more powerful when the solution comes from the client rather than the therapist? Is it C, all responsibility for changing one's behavior lies with the client? Or is it D, developing discrepancies help to elicit change talk? So we're just up to 52% who've answered.
All right, getting there.
Yep.
And then I'll spend about 5 or 6 minutes talking about CBT and then maybe close it for a couple questions if we have any.
Sure, absolutely. Yep.
Like I said, it's very challenging to cover this topic in an hour. I would cover this topic in a day or two usually.
Right, yeah.
So this is really a brief overview.
Well, it's been great, and I've loved the piece on motivational interviewing. It's a skill and an art, right?
Absolutely, yeah.
Okay, so
all right,
let's end the polling, and I'll share the results.
Okay, so most of you said, 56% of you said A, MI is a form of treatment that is non-directive. That's correct. It is actually a directive form of treatment. Okay. So the focus is helping people in the direction of recovery, however that's defined. So if you think about like more experiential and humanistic forms of therapy, which is actually the basis of motivational interviewing, Carl Rogers and so forth, those are actually non-directive forms of treatment. But Miller and Rolnick wanted motivational interviewing to be directive. Directive in that it's about helping people to recover from addiction. So there is an aim there. There's a goal there. 20% of you said developing discrepancies helps to elicit change talk. That might have been a bit of a tricky one because I did talk about developing the discrepancy being putting out there both sides of the coin, right? The behavior side, which is continuing to gamble, and the value side, which is the argument against the gambling that came from the client. Ultimately, it does actually move change talk forward because people will usually say, you're right. My behavior of continuing to go to the casino is inconsistent with my values of being a better husband, right? So, so that being the case, developing discrepancies is a very powerful tool for eliciting change talk. All responsibility lies with the client. From a motivational interviewing standpoint, that's true, with the exception of anything that would be dangerous enough to move someone where you're really concerned with the person. Interventions are more powerful when the solution comes from the client rather than the therapist. That's also true. If you can get your client to say what they need to do, it's going to be far more powerful than if the therapist says it to them. So, okay, good job, everybody. I'm going to move on. We'll talk very briefly about cognitive behavior therapy. And as I mentioned previously, cognitive behavior therapy is the treatment approach that has the most evidence for efficacy. Depending on their focus, some treatments have been called cognitive therapy, Some have been called cognitive behavior therapy. Both really use an approach of looking at cognitions or thinking patterns, focusing on things like cognitive distortions around gambling or addictive behaviors, whatever the addictive behavior is. Cognitive behavior therapy differs from cognitive therapy a little bit because it also includes behavioral components like reinforcement of non-gambling behaviors or encouraging problem solving or using social skills building or relapse prevention. So it may seem like a kind of a false sort of dichotomy here, but there are different. It has been packaged in different ways in the research literature. So the goals of cognitive therapy are to understand the beliefs that relate to gambling or drug use, to learn how to evaluate objective evidence that supports or contradicts gambling beliefs, and to learn how to develop healthy alternative beliefs related to gambling. And this approach was really started back in the 70s by a psychiatrist by the name of Aaron Beck. Many of you may have heard of Aaron Beck, and many of you may have heard of Judith Beck as well. It's his daughter who's continued his work and continues to run the institute that Aaron Beck created back in the 80s and 70s. Aaron Beck's idea was that cognition is organized into core beliefs, intermediate thoughts, and automatic thoughts. And we'll talk a little bit about what these are. So in a nutshell, this is from Judith Beck. The cognitive model proposes that dysfunctional thinking, which influences a patient's mood and behavior, is common to all psychological disturbances. So the idea here is that underlying all psychological disturbances are dysfunctional thinking patterns. When people learn to evaluate their thinking in a more realistic and adaptive way, they experience improvement in their emotional state and in their behavior. So when people are able to change their thinking in certain ways, that can help them. And we see this most often in things like anxiety disorders and depression. So for example, someone who's very severely depressed, their thinking pattern tends to be very negative, especially about oneself and the world in which they live. And it tends to be very narrow or focused and sort of tunnel vision type of approach. The idea here would be to help a person sort of expand that approach and also to improve their outlook in terms of focusing on more positive sort of aspects. Many of you may have heard of something called the cognitive triad. Oftentimes we think about how one sort of thinks in terms of their perceptions about themselves, their perceptions about their prospects, their experiences, and their perceptions about what the future potentially will bring. So someone who might be depressed, for example, might feel like I'm not a good person, my life is terrible, and I don't think things are going to get any better for me, right? You can think about that in terms of gambling as well. A person who experiences gambling problems might say, you know, I'm not a worthy person. I've had a string of bad luck, and I've got a lot of bills I need to pay. In the future, I just need a hot streak, and maybe I'll be able to get that money back. When we're thinking about these sort of elements of the cognitive model, you can think of core beliefs, intermediate beliefs, and automatic thoughts. Our core beliefs are the most fundamental level of global and overgeneralized beliefs. These are things like, how do we generally deep down feel about ourselves? How do we deep down feel about our environment? Do we feel generally like we're safe? Do we feel like we're good people? Do we feel like we're worthy of being loved or being liked? And so forth. A lot of clients that I've worked with over time who are depressed often had messages sort of sent to them when they were very young that they were unworthy, they were unlovable, maybe they were traumatized, maybe they experienced sexual assault or sexual abuse in childhood or other types of abuse, and sort of really internalized a sense of self as being unlovable or unlikable. Our intermediate beliefs tend to be those rules or assumptions that we live by on a day-to-day basis. So for example, someone may have the assumption that people who are addicted are weak, right? If I work hard enough, maybe I could stop gambling, or maybe I can't stop. These are sort of the things that we often sort of think of. Our automatic thoughts are our most sort of superficial level of thinking and cognitions. They're the words, the thoughts, and emotions that go through our mind at any given time. It could be something as simple as, if I think about What am I going to have for dinner? I don't even know what's in my refrigerator. That would be an automatic thought. It doesn't necessarily inform our intermediate beliefs or core beliefs, but it's a thought that goes through our head. When someone has a gambling problem and they're driving along the highway and they see a road sign for the local casino, they might suddenly have an automatic thought of, oh yeah, exit 52 is where I go to get off to go to this casino. It's an automatic thought. It's influenced by their core beliefs and their memories and other things. It's also influenced by situations, and those situations and automatic thoughts often lead to reactions and emotional experiences. And it's usually cyclical. So that's from a cognitive perspective. I think an important part of this. And Kathy Carroll has a manual called A Cognitive Behavioral Approach to Treating Cocaine Addiction. And she is a really, I think, a very important but very sort of brief sort of definition of CBT. Very simply put, CBT attempts to help patients recognize, avoid, and cope. That is, recognize the situation in which they're most likely to use, in this case, she's talking about cocaine, avoid these situations when appropriate, and cope effectively with a range of problems and problematic behaviors associated with addictive behaviors, whatever they may be. I realize we're at the end of our time, so we didn't get too far into cognitive behavior therapy, but I do want to leave you with one more, I think, really useful sort of approach. And I actually use this graph with clients sometimes. And it's by Katie Witzkowitz and Ellen Marlatt, published in 2004 in the journal American Psychologist. And they sort of put down relapse into this sort of model. Someone who is in recovery, when they hit a high-risk situation, they'll either have effective or ineffective coping. Someone who has effective coping is going to feel an increase in self-efficacy. They're going to decrease their probability of relapse. Somebody who gets into a high-risk situation is going to have ineffective coping responses. They're going to have a decrease in their self-efficacy and positive outcome expectancies around the gambling or the drug use, which means basically they feel like if they go gamble, they'll feel better. There's going to be an initial sort of lapse into the gambling, which is followed by an abstinence violation effect, which basically means they just felt like they blew it, and perceived positive effects of continuing to gamble, and an increased probability of full-blown relapse. From a cognitive behavioral standpoint, what we want to do is we want to take this model and find better ways to cope at each stage of this model. So for example, can we cope better at the stage of identifying a high-risk situation? Can we cope better after initial gambling? Can we cope better even after the person is relapsed? So trying to find ways that we can help people cope a little bit better with each of these stages is, I think, really the most important aspect of cognitive behavioral approach, in addition to helping to change a person's dysfunctional thinking patterns. So given that we're at just over 2 o'clock, I'll maybe hand it back to Robbie and see where we want to go here.
Oh, yeah, no, that's fine. And thank you, Dave. This has been great. I love both MI and CBT, but and everybody who has to go, we understand. But if you got a couple of minutes, Dave, for questions. And again, we thank you, everybody who's on and who has to go off. We understand. And I look forward to hearing from you next Friday, the 29th at noon Central Standard on our talk on IPV and problem gambling. Okay, so we've got a few questions here. Okay, let's see. Okay. Yes, we'll have the slides, Steve. We'll have the slides and the recorded. I'll have, yeah. If I'll, you can email me and I'll perhaps reach out to you, Dave, and we'll have the recorded version of this on the website too. Let's see here. Now, Ellen had asked earlier, and it was right around 2 o'clock, about a trigger. It might have been about maybe a slide back. And I'm sorry, I must have. Yeah, but she was asking about a trigger. Maybe it was a slide back. I don't know.
We were going to get into talking about triggers, which we didn't quite get to.
Okay.
Triggers are very important in terms of identifying triggers. which could be emotional states or external things like people or places or specific cues in one's environments. That's one of the more important sort of aspects of CBT is identifying triggers. I don't know if that was the question.
Okay. Let's see here. Someone's asking about poll questions. It's okay, guys. We just had 2 this time, and that's all right. Let me see what
I
other
could give you
questions
a third, but it might not be fair.
they might have slightly, exactly, yeah. Ellen asked too. Let's see here. She asked when we saw a sign for a casino, and no, okay. She was I guess with the trigger she was talking about. Seeing the sign or the exit that you had spoke about. Remember with the example, it being a trigger. Yeah. So I guess she was just.
Well, what a trigger kind of is, or
yes, yeah.
A trigger is like a cue, or trigger or a cue. We sometimes also call it an antecedent when we talk about like functional analysis, which I'll put the slide up here, which is something that basically triggers us, something that cues us to feel a certain way, right? You might see a road sign for a casino, and then we start to feel like we want to go because it's like, oh yeah, the casino's here, right? We might have these thoughts, these feelings, these behaviors that sort of change at that point.
Yep.
Which leads to our gambling or not gambling, which leads to positive and negative consequences, short and long-term consequences.
Yes, and she looks like she concurs, agrees.
Right.
Yes. Any other questions, guys, while we have Dr. Ledgerwood? That might be it. And thank you again, Dave. This has been great. I really like to talk, on the MI and even we got a great healthy chunk of CBT here at the end too. So
yeah.
So
we'll be happy to send the slides out to like power like the PDF version of the slides for people.
Yep. Okay, yeah. And if you guys want to email me, and Dave, I'll get them from you if that's all right. I can send them out. Sure. And again, the recorded version will be on. And Ellen asked for more CBT, so maybe on the next one we'll. I've heard some of this talk, I believe, Dave. Yeah.
CBT only one.
Yeah, right.
I could talk about CBT for days, probably. So.
Yeah, exactly. Yeah, it's a very popular. I know. I love it myself. I use it myself, or I try to the best that I can. But it's a very successful technique. So, okay, well, guys, thank you very much. Thank you, Dave, again, and everybody's thanking you now as we're exiting. So,
thank you very much, everybody.
Yep, and we look forward to the next one.
Sounds great. We'll talk to you soon.
Thank you, Dave. Thanks, everybody. Okay.